start with the multiple choice questions we did. I mean, I put for the test. It was just like for fun sake. We'll discuss that. Can you all please mute yourself? Dr. Betty, there is some technical glitch. People are saying they cannot hear.
They should be able to hear.
Yeah, you can hear me, right?
Yes, I can hear you perfectly.
Okay. So probably there is some problem at your end. Yeah, Dr. Bedi, can you just mute everyone? And when I kind of start go over the stuff, we can always unmute and ask them. I want to do the questions and answer by all of you participating in the question answer session. But anyway, I'll just ask one by one and we'll go like that. Or Dr. Bedi is going to. Dr. Bedi, can you just have one person just pick one of them and who can take the first question? Anyone?
Please raise your hand.
Or anyone can, I mean, why this middle thing is coming in between? I don't know. There's a box coming. There's a box coming up, yeah. So anyone, because if I'm just reading the questions and tell you what it is, it's going to be very, very monotonous. I mean, all of you are practicing surgical pathology, so whoever is going to volunteer, and we are going to unmute that person. Why is this central screen is coming, Dr. Bedi?
That is because I'm looking at the participants also.
Okay, I'm so sorry, yeah.
But nobody is raising their hands.
So we can just pick one of them. Maybe Praveen, you want to take this? That is the first name I see in the screen.
Hello.
Yeah, hi, how are you?
Fine, sir.
Yeah, so why don't you take the first one? So it is a patient with a colon cancer who has been found to have 2 positive regional lymph nodes. Regional means they are present in the pericolonic adipose tissue, and there is a tumor deposit in the subserosal fat.
Okay.
What is the correct PN staging?
Like what I should say, how I should say. Trying to form some sentences, form some,
there are a lot of noises coming, Dr. Bedi. I mean, it's kind of annoying when you have like so much of noise going on. We probably have to cancel the class. Okay, Praveen, please go ahead.
Praveen, you can speak.
Yeah, you can start speaking, Praveen.
Praveen, you have to unmute again. You have muted yourself again.
Okay, I'll just go over the questions, not an issue. So this is basically we do not know about the T stage or the extent of invasion into the wall of the colon, but we have 2 positive regional lymph nodes and 1 deposit in the subserosa. So what is the correct PN staging in this? So if we go to the choice B, where we have it is N1C when the tumor deposit in the subserosa, the mesentery, or in the non-peritonealized pericolonic or perirectal or the mesorectal tissue. That is not correct because we have here two positive nodes and there is a nodular tumor deposit in the subserosa. So when you see a nodular tumor deposit in the subserosa, that's counted as a lymph node. So when you have it is basically a N1B tumor where there is tumor metastasis in the lymph node and involving up to 3 regional lymph nodes. So that should be the correct answer, is 1A. And in the second question, we have a patient presenting with rectal bleeding and he is found to have an adenocarcinoma of the sigmoid colon. And there is an enlarged axillary lymph node. So there is an axillary lymph node. The patient underwent left hemicolectomy and biopsy of the axillary lymph node. He has adenocarcinoma that involves the pericolonic tissue without penetrating the visceral peritoneum. And so it is a T3 tumor. It has gone beyond the muscularis propria, but it is within the pericolonic adipose tissue, and it hasn't gone beyond the visceral peritoneum. There are 8 regional lymph nodes, and there is metastasis in the. So there are 8 positive regional lymph nodes which are in the pericolonic fat, and there is a metastasis to the axillary lymph node. So what is the TNM staging? Who is going to answer this? We know it is a T3 disease, so it's going to be either B or C. So is it going to just a N2 disease, or we have a M in this? Yeah, it is going to be, Sangeeta answered correctly, 2 of them actually. So it's the T3, N2 and M1 disease. So anything beyond the premises of that organ. So it is away from that organ. So the distance spread to a non-contiguous lymph node, so that is in the axilla. So it is a M1 disease, and end stage would be 2 with a T of 3. Next. Yeah, sporadic MMR, microsatellite mismatch repair deficient colorectal cancer. So when you say it is a sporadic cancer, that means the tumor, it is not inherited from the parents. So, and the mutation is present in the tumor but not present elsewhere in the body. So it is due to promoter hypermethylation of which of the following genes. So let's talk about what is MMR. There are 4 genes in MMR. Classically we test for, and MMR testing is done by IHC and MSI. We do it either by PCR or by NGS. So the 4 things is MLH1 makes a dimer with PMS2 and MSS2 makes a dimer with MSH6. So that you know. Suppose you are doing an IHC and you see MLH1 loss or MLH1 and PMS2 loss, but the rest are normal. They're stained normally. So the first thing you think about is there is a promoter region hypermethylation of the MLH1 gene, which gives rise to a loss of MLH1 expression as a protein, also the PMS2 because they are interrelated. And so every gene has a promoter. If the promoter is hypermethylated, the gene is inactive and it doesn't transcribe into a protein and translate into a protein. So what you see, so that is the first cause, and that is a sporadic promoter hypermethylation of MLH gene. If the MLH1, you exclude the Dr. B, the central thing is coming. So if you exclude the promoter hypermethylation of MLH1 gene, the second thing you see that is normal, you look for BRAF V600E point mutation. If BRAF V600E mutation is normal, then the third thing you think about a Lynch. So MLH1 and PMS2 dimer loss, or isolated MLH1 loss or isolated PMS2 loss is not always Lynch. You have to exclude a promoter hypermethylation of the MLH1 gene. Number 2 is looking for the BRAF V600E point mutation, or once you exclude these 2, it is going to qualify for a testing for Lynch. Okay, next one. Next question. Sporadic MMR deficient colorectal cancer is due to promoter hypermethylation of which of the following genes? Again, this is going to be MLH1. Number 4. Can I see the number 4 question? Lynch syndrome usually arises from a germline mutation in the coding region for mismatch repair protein. Germline mutation in which of the following gene could cause Lynch syndrome? Yeah, it is going to be C, because CDH1 is nothing but cyclin D1 and BRAF. These are non-Lynch associated tumor. BRAF, CDH1 and MUTYH, EPCAM mutation, or if there is EPCAM mutation in the germline, EPCAM mutation leads to Lynch. Other than the classic fours, MLH1, PMS2, MSS2 and MSS6. Question number 5. Can I see the question number 5, Dr. Bedi? You have to, Which of the following is not currently a typical use of intraoperative frozen section consultation in breast cancer management? So for breast cancer management, the first thing you always do, the frozen section is done to assess the axillary sentinel lymph node. So surgeon is going to send you the sentinel lymph node, which is the first draining lymph node. And if you say the sentinel lymph node is negative, the surgeon is not going to do a complete axillary dissection. If your sentinel lymph node is positive, then that calls for a axillary dissection. So that is one. Number 2 is if the surgeon is going for a nipple preserving or a breast conservation surgery, then the margins are very important. So margin evaluation is done. So that is another indication. The nipple margin evaluation is nipple margin mastectomy. That is one. Frozen section is never done for a primary diagnosis for a same-day surgical management. Though I have seen in India a lot of people, they do it because they want to rush, they don't want to lose the patient, and the compliance is not great here. So they do it, but that is not an ideal indication for doing intraoperative frozen section consultation in breast cancer. Primary diagnosis of breast cancer for the same day. But the basic indications had to look for the margin, look for the nipple margin, and sentinel lymph node evaluation. Question number 6. Okay, can you scroll up, Dr. Bedi? Which all of the following artifacts are artifacts of frozen section except alteration of architectural features makes benign lesions such as sclerosing adenosis may closely mimic a cancer, artifact of clepting around tumor cell mimic lymphovascular invasion, pseudo invasion in papillary lesion. So these are known artifacts of frozen section. Next, the most useful immunostain in the differential diagnosis of usual ductal hyperplasia and atypical ductal hyperplasia. Which stain you use? You basically use 2 stains. One is estrogen receptor and CK5/6 as a cytokeratin 5/6. So what happens in usual ductal hyperplasia? It is a duct filling process by proliferation of myoepithelial cells and epithelial cells. So if you do a CK5/6, you see CK5/6 staining inside the ductal proliferation. Outside, surrounding the ductal proliferation, it would be very kind of a diffuse. Whereas if you do it in ADH is a neoplastic ductal epithelial cell proliferation. So the myoepithelium is not kind of proliferating. So what you see, only the myoepithelial cell lining in the periphery, and the center is negative for myoepithelial cell positivity. Rather, you see strong estrogen receptor positivity in atypical ductal hyperplasia. CK5/6 staining is very useful. So CK5/6 and ER staining is very useful in differentiating UDH from ADH or low-grade DCIS, because low-grade DCIS and ADH, they will show diffuse ER positivity in the center with myoepithelial cell staining in the periphery, where UDH will show ER would be either weak, negative, or a mosaic pattern of positivity, and CK5/6 is going to be strong and diffusely positive, indicating a proliferation of both ductal epithelial and peripheral myoepithelial cells. Question number 8. Can we go to the question number 8? Which of the following, what is the PN category for a patient with 1 macrometastasis and 2 micrometastasis and 2 nodes with isolated tumor cells? Yes. So Sangeeta has answered this as C. So C is the correct answer because what you see, the macro metastasis is important. And we have 2 micrometastases. So anyway, we are within the less than 3 category, and the ITCs are not considered as carry towards the end stage. We'll get into that in the second class of breast, because I have divided a breast lectures into 4 classes. One is for HER2 and ERPR and other biomolecules, and one for reporting of breast cancer, and one for sentinel, one for grossing. So we'll get into that. Then question number 9, in an invasive breast cancer, if HER2 to CEF17 ratio is less than 2, an average copy number per cell is 6. So if HER2 to CEF17 ratio is less than 2 and HER2 average copy number of HER2 is less than 4, it is a clear-cut negative case. If the HER2 to CEF17 ratio is more than 2 and the average copy number is more than 4, it is a clear-cut positive case. So here the problem is the ratio is less than 2, but your average copy number per cell is 6. So this is a category where we have to go back to the IHC and see if the IHC is 1 plus, 0, 2 plus, or 3 plus. If IHC is 0 or 1 plus, it is a HER2 non-amplified tumor. If the IHC is 2 plus and 3 plus, in this scenario, as per the 2018 CAP ASCO guideline, the tumor is HER2 amplified. Is this clear to all of you? Question number 9. I know few people, they have already attended my breast lecture, so they are saying all the correct answer, but is it clear to all of you? Question number 9. Okay, because we are going to have this thing again in the HER2 literature in detail. The question number 10, in an invasive breast cancer, if the ratio is less than 2, but the copy number is between 4 to 6. If the copy number is between 4 to 6, it is not amplified if the HER2 IHC is equivocal or 2 plus category. If the HER2 IHC is 3 plus, then in this scenario, when the ratio is less than 2 and the copy number is between 4 to 6, if the IHC is 3 plus, then the tumor is amplified. Question number 11. Can we have the question number 11, Dr. Bedi? Yeah. Then here the ratio is less than 2 and copy number is between 4 to 6 with 3 plus, then it is amplified. The question number 12 is, isolated tumor cells are defined as significant factor and as considered as metastasis for staging purposes. True or false? So ITCs are defined as significant considered metastasis for staging purposes? No, they are not considered as, they are like, it is going to alert the oncosurgeon and the medical oncologist for additional therapy, but it is not going to make upstage the disease. So it is no. Which of the following diagnostic modalities do we use for the diagnosis of mesonephric type adenocarcinoma of the endometrium? So mesonephric type adenocarcinomas of the endometrium and cervix, they are classically GATA3 positive and CD10 positive tumors. So just remember, these are hormone receptor negative tumors and they express GATA3 and PAX8 because they look like mesonephros, from where the kidney develops. So they are PAX8 and GATA3 positive tumors like other mesonephric structures. Next, question number 14. Which of the following about endometrial cancer is not true? This is again another good question. Copy number high tumors involve mutation in TP53. So this is for any tumor across the body. Any tumor with a TP53 mutation will have high tumor mutational burden, lot of mutations, and they're high-grade tumors. And copy number low tumors are usually because of loss of tumor suppressor gene like LDR1 and PTEN and PI3 kinase. With PI3 kinase and KRAS are not tumor suppressor, they are oncogenes, but PTEN, LDR1 and tumor suppressor, these are copy number low tumors. Any endometrial tumor with a pole E mutation, they are going to have a better prognosis, because POL-E mutated tumors, regardless of the MSI status, their copy number high or low, they are going to behave in a good way. So we always do the POL-E testing first. Question number 15. Some endometrial cancers harbor more than one molecular event and are referred to as tumor with multiple genomic classifier. Recent evidence suggests that MMR deficiency and POL mutations supersede TP53 alteration in terms of clinical behavior. That means if there is MMR deficiency and POL mutation, or there is a POL mutation, even if TP53 is there, the tumor is going to behave in a good way, in a better way, which is true, because it is the more significant genomic classifier. Question number 16. Can I see the question properly, Dr. Bedi? Tumor budding is linked to adverse prognostic outcome in colorectal cancer patients in which of the following scenario? 16. Actually, the entire question is not visible, Dr. Bedi, for some reason. If it is a tumor budding in stage 1 colorectal cancer, it is not the highly adverse. It has some relationship to the prognostic factor, but it is not an highly aggressive because the tumor is stage 1. In a preoperative staging, tumor budding in the biopsy material is not helpful. No. In a preoperative staging, in a biopsy, if you see tumor budding, you have to mention in your report. It is a significant predictor. Then, a malignant polyp, detection of tumor bud is a risk factor. Yes, in a malignant polyp, if you see intramucosal carcinoma and high-risk tumor bud, then it is a significant predictor for occult lymph node metastasis. Question number 17. In which of the following scenario would you consider suggesting HER2 testing in gynecologic tract malignancy? Is recommended for possible treatment for advanced stage and recurrent serous endometrial and serous ovarian cancer. So if it is a high-grade serous ovarian or high-grade serous endometrial cancer and the tumor is in the advanced stage, metastatic or recurrent, then HER2 testing is recommended. Question number 18. Can I see the question number 18? Yeah. 18 is pagidism of nipple is equivalent to stage 4? No, it is not. It is not a stage 4. You need to show skin ulceration to call it, not nipple ulceration. It has to be a skin ulceration, or it has to be a non-pagetoid. Paget is just an involvement. It can be by DCIS, it can be by invasive cancer, but unless there is ulceration of the skin, you cannot call it as a stage 4 cancer. Do you report microcystic, elongated, fragmented pattern of invasion in the final diagnosis of endometrial cancer? You all should report this one, because this is something, it's a good prognostic indicator in endometrial cancer. It's a very peculiar pattern of invasion. Question number 20. Do you report exact percentage of component of mixed carcinoma and carcinosarcoma? You should always do that, because that has again prognostic value. Then 22. We'll go to the question number 22. Partial resection of mesocolic envelope is, in case of a hemicolectomy specimen on the left side, it has a poor outcome. Metastatic liver biopsy is super to primary colon. Suppose you have a colon cancer and you have a colon cancer metastatic to liver. You have both the blocks available. Which one you are going to use for RAS testing or RAF testing? You can use any of these, because none of these is superior. They both are equally important. So you can basically use primary or the metastatic tumor. 24 is homologous recombination repair deficiency mutation is, DNA repair deficiency mutation is commonly associated with. Can I see the choices? 24, question number 24. Dr. Bedi, question number 24. I need to see the choices. So HRD mutation is actually very, very prevalent. In association with cribriform pattern 4 prostate cancer, and the cribriform pattern 4 prostate cancer with HRD mutation are they often show radio resistance to radiation therapy. So whenever we have a cribriform pattern for prostate cancer, it is required from the pathologist to tell them what percentage of grade lesion pattern for cancer is cribriform and what percentage is non-cribriform, and if there is associated intraductal carcinoma of prostate or not, and always advise in the report or in the comment section for a HRD mutation. And HRD mutation is basically look into BRCA2, BRCA1, PALB2, ATM, check 1, check 2, all this. These are the genes which are responsible for homologous recombination repair of the DNA. A renal tumor of the size 5 centimeter with renal sinus involvement. When the renal sinus is involved, the tumor is going to be automatically a T3A tumor. Then question number 26. Can I see the question number 26? What grading system is recommended? Chances of a renal tumor. If a renal tumor has a size of 7 centimeter, more than 7 centimeter. So what is the chance of having a renal sinus involvement in such tumor is about 90%. So if your resident or fellow is coming to you with an 8 centimeter tumor saying grossly the renal tumor is not involved, please go back to the specimen because it is difficult to believe. If a tumor is more than 7 centimeter in the kidney specimen, the chances of renal sinus involvement is almost 90%. What it may be, I mean, the 10% is always there, but still, if a resident or fellow is saying it is negative, then please go back to the specimen and look at it. Or tell that person to go back to the specimen and see it again, because chances of renal sinus involvement is very high. What grading system is recommended for endometrial carcinoma in WHO 2021 and 22 is high versus low instead of having a FIGO grading system. So I think we're done with this few questions, and we'll have multiple tests throughout the session. So any question from you guys? I can take a few questions, then we'll start the breast.
I have allowed you to unmute. Anybody can unmute now.
Yeah, anyone can unmute and ask questions. I mean, we are going to discuss all these in different chapters, in different classes, but you can always ask questions now. No question? They all did very well in the test. I was looking at it. Okay, Dr. Bedi, I can start my screen, if you can.
Yes.
Okay, cool. So is it like full screen or not?
No, not yet full screen.
Okay, so let me now. Still not yet? Just stop. How about now?
Yes, now it is full screen.
Okay, cool. So what we are going to do, this is a breast part 1. Probably we'll do half an hour for the next 30 minutes. And it will continue with the 3 or 4 more classes. So in breast, what do we usually get as specimens? So in the younger breast, they go for ultrasound, and a little middle-aged to older breast, they go for mammography. just in a denser versus a rarefied breast to look into the lesion, and accordingly we go for a BI-RAD scoring. And the BI-RAD is basically they take into radiologic image and score it. And not a high BI-RAD is not always a malignancy. It can be inflammatory lesion like chronic cystic neutrophilic granulomatous mastitis, fat necrosis. They usually have a high BI-RAD. Similarly, pseudoangiomatous hyperplasia will have an intermediate BI-RAD, and sometimes low-grade DCS will have a low-grade BI-RAD. So in that way, BI-RAD is not. So whenever you have a lesion in the breast, either as a calcification, so the few things we can have, either there is nothing on mammography, there is calcification, if it's a regular round calcification or irregular spicules of calcification. So the surgeon wants to chase after that. For that, they do an ultrasound guided or a mammographic guided core needle biopsy. And typically these biopsies have a thickness or a width of 0.1 centimeter, and they take multiple biopsies and give it to us. Or we can have a local excision for the calcification, and the where is there to guide the calcification or the lesion. Or it can be a small excisional biopsy or a diagnostic localization specimen. We can also get a segmental excision, which can be a wedge excision, a partial mastectomy, re-excision specimens like there is a lumpectomy before and there is a post-lumpectomy mastectomy, or just an excision of the re-excision of the lumpectomy cavity to clear the margin. Then mastectomy can be a skin sparing mastectomy, nipple sparing mastectomy, modified radical mastectomy, Halsted, which includes the pectoralis, or it can be just a completion mastectomy following lumpectomy, the tumor is out, and risk reducing mastectomy, that is the prophylactic mastectomy if the patient is a BRCA carrier or BRCA carrier. Or you can have a subcutaneous mastectomy and re-excision specimen. Then other can be just a save of the cavity or a bed biopsy. If there is a lesion in duct, like duct papillomas, or there is bleeding per nipple, secretions, that they go for a microdocectomy or Hatfield's procedure or a total duct excision. Then sentinel lymph node is done fast. They put a dye in the areolar area, and this is going to drain to the first draining lymph node, the sentinel lymph node. And if the sentinel lymph node is negative, they stop there. If the sentinel lymph node is positive, they go for an axillary clearance. In the axillary node clearance, usually we get the level 1 and 2 node, and some surgeons, they also include the level 3 node, and sometimes they send the level 3 node in a separate container or along with the 1 and 2, and interpectoral soft tissues. And also we get a vacuum assisted core excision specimens. So this diagnostic localization excision specimens, so if I get into that, let me just minimize this here. So these specimens are produced when a preoperative diagnosis has not been made. That means the FNAC is not done, or there is no mass to do FNA. It was more of calcification, or there are suspicious radiologic or clinical finding, or when the preoperative diagnosis is of an indeterminate category, that is a C3B3 or a C4B4 lesion. These specimens, when you receive, you have to ink the margin, weigh it. I always weigh all my breast specimens. It kind of sounds a little funny, but I weigh it. And you measure it in 3 dimensions. Then you serially section perpendicular to the long axis. Suppose it is from lateral to medial, it is 5 centimeter, and superior to inferior is 3 centimeter. So you make perpendicular from lateral to medial. That means you go perpendicular to the long axis after inking, and the thickness of the slices should be 3 to 5 millimeter. Specimen containing no mass lesion, just microcalcification, you require specimen fly. So what you do in this case, if there is no mass lesion but there is microcalcification and mammography, you first ink it, then lay down all the slices on the surface of your table. Then you x-ray those slices. Once you x-ray it, it will be very easy for you to identify the slices with calcification. You block them together in different. And so you mentioned slides number 2, slides number 4, slides number 7 with calcification in block A1, B1 and C1, and the other should be blocked separately. The sampling technique and the number of blocks taken are clearly dependent on the size of the specimen and the size of the abnormalities. Ideally, in such kind of specimen, the entire specimen should be put through and blocks should be taken to enable a measurement of the histologic size of the section. So what I do, suppose I have 5 slices or 7 slices, I will have mentioned the medial end is the slice number 1 and the lateral end is the slice number 7. And I designate, I make pictures on the back of the requisition sheet and I mention which block belongs to which particular slices. So that way you can construct the specimen from your slides. Then wide local excision for invasive carcinoma presenting as a mass lesion. We are not talking about mastectomy, lumpectomy yet. So for these cases with preoperative diagnosis of malignancy and are deemed to be suitable for breast conserving surgery. These specimens should be again weighed and measured, and the specimens should be incised to have prompt formalin into the specimen, and the fixation should not be less than 6 hours and more than 48 hours ideally, and should be inked and should be sliced either before fixation or after fixation. Then accurate measurement of the size and detailed examination of the margin status should be done. So this is something you need to see what I was just telling. Let me just put it somewhere.
वो आपका रखा हुआ है वहाँ पे किचन में थाली में, और वो सांभर ऊपर में उसको कटोरी में निकाल लीजिए। साहू जी उसको बुलाइए, वीडियो एज स्टॉप लिखा है।
Okay, so what ideally the surgeons, they do short superior and long lateral. That is, the long suture is usually lateral and short is superior. So you can construct which one is superior, which one is medial, lateral, inferior, anterior and posterior. And I ideally use 6 inks, like a blue, a black, a orange, a red and a yellow or a green ink. And so accordingly you know, and ink it, suppose this is the long axis, this is the longest axis. So instead of saying 5 into 4 into 2 centimeter, I like the lumpectomy, the oriented lumpectomy specimen measures 5 centimeter from lateral to medial, 3 centimeter from superior to inferior, and 2 centimeter from anterior to posterior. And avoid using the word deep margin, because deep margin is basically the posterior margin. Then you have to mention which all slices, like here it is 1, 2, 3, 4, 5, 6. So the 7th, 8th and the 9th slice has the lesion, the wide circumscribed lesion. And what is the dimension, distance of the lesion from all the 6 margins? So you have to separate it out and you block these areas the way it is. I think it is going like below the slide. I have to like send you this. So accordingly, you have to designate which block is what. And these are very important margin. The lateral, and this is the lateral and this is the medial margin. So what you do, once you have the lateral margin, so you take this entire slice out and cut it perpendicularly. So that would be up, and you designate it as A8 or A9, whatever it is, the last section. It is the perpendicular section of the saved lateral margin. So it is the same margin. These are perpendicular margin. If I'm taking like this with the superior, if I'm taking like this with the tumor, is the tumor with the superior margin perpendicular section. But if you have, or the tumor with the anterior margin, perpendicular section. But if you are taking the lateral margin and the medial margin, they are essentially saved or en-face margin, and you perpendicularly slice these margins. So you designate the lateral margin perpendicular sections of the saved margin. Excuse me, give me 1 second. So you mention it as a perpendicular margin of the the perpendicular sections of the OncoPath are the same margin. Any question on this? You guys can ask. Dr. Betty, you can like kind of unmute them, they can ask. There is something in the chat box. Any question on this slide?
Hello, good evening, sir.
Good evening.
Sir, even if the tumor is very far away from the medial and lateral margin, should we have to put that medial and lateral margin?
Yeah, you have to, even if it is far away, because in breast is a tubular organ. Breast and prostate are organs with lot of pipes, right? So they have a ductal system. So you never know the tumor is somewhere, like suppose you see a ADH or a focus of DCIs in the lateral or medial margin.
And after slicing that perpendicular slices, we have to put all that perpendicular
All the
slices.
perpendicular slices, yes.
Okay.
So breast is one thing. It is kind of, I know it is like a lot of blocks and sometimes it is not possible. Yeah. So in that case, like if you think like it is little far up, you can put a few of those, but mostly I would say putting usually the lateral and the medial and the small slices. If you see, these are small slices. So once you cut it perpendicularly, it will come in one or maximum two cassettes. Okay. Any more questions?
Okay, sir. Thank you.
Thanks. And you don't have to put all the three slices for the tumor. If it's a small tumor, you can take tumor section along with the margins. For these slices, no, you can basically take in such a way you are taking the tumor along with the margins. So you don't have to use these slices. Just physical examination is fine. Gross examination. And you take the tumor with the closest margin. Like suppose this one, if I draw a line, this one is probably closer to this ink. So you take that one. And in breast, in this, you cannot take safe margin. You take a perpendicular margin. In breast, why safe margins are not advised? Like in GI tract, if the tumor is like 10 centimeter away from the proximal margin, we take an OncoPath or a safe margin. But in breast, we always advise going for a perpendicular margin. Why? Who is going to answer? In breast and also in prostate, we always ask for a perpendicular margin. Why? Because these organs are organs with ducts and lobules. And duct system is like a pipe, they're interconnected. So if you take a safe margin, probably you are losing out the bottom of the pipe and the tumor might be spreading like this and stopped here. So you need to take a perpendicular margin to see the entire ductal-lobular system. Therefore, any organ like prostate and breast with a pipe-like structure or a ductal-lobular arrangement, you need to take a perpendicular margin to see the entire alignment and the relationship of the tumor with the ductal-lobular system. They can be pagetoid spread through the duct. And these are very important in the lumpectomy specimen or the breast conservation surgery because a majority of the breast is still there inside the body. If it's a mastectomy, it's probably you don't have to take such kind of sections in mastectomy. You take one section. That's fine. And if you just say like medial margin is far away, you're not taking a section, it's also fine. But in lumpectomy, breast conservation surgery is nipple sparing mastectomy, you have to take all these margins. Any question or should I go to the next slide? Certain wide localization excisions for DCIS presenting as mammographic calcification. So the surgeon should mark the nipple duct margin here, is very important. And DCIs track towards, normally what happens, the DCIs, they have a tendency to track towards the nipple. And this specimen should be x-rayed intraoperatively if there is no mass, just calcification. prior to the receipt in order to confirm the presence of the lesion within the specimen. This is typically done in West and in the big centers. And we get a lot of breast cases across our laboratory in Gurgaon. Some of them, they're like dedicated breast surgeons, so they usually x-ray the specimen before sending it to us. The specimen should be weighed and measured in 3 dimensions, and we do have a faxitron machine in our grossing room, so we x-ray the slices. If there is just calcification, no mass lesion. The specimen excision margins should be inked, and the specimen can be sliced either before or after fixation. And macrophotography or the schematic diagram may also assist in recording macroscopic finding and the block map, as well as identifying individual sample margins. Sampling may be facilitated by the identification of a radiologic marker like clip, collagen, or a coil, and you can see the tissue changes relating to previous core biopsy that can also mark the lesion. Then if there is a cavity save or a biopsy specimen, so it is usually you take a circumferential margin of the save or the biopsy of the wide local excision specimen and examine by pathologists to allow more extensive examination of the relevant surgical margin. So the cavity save specimen submitted by the surgeons are generally is a portion of fibroadipose tissue with a marker, or there is a blue ink marking one area. So what you do, you basically, if there is a blue ink, you ink the other surface, then you put through that entire area, taking perpendicular to the long axis. And it should be blocked in total. And if it is a larger size, then you only block the areas which is densest, which has a lot of white areas, and less rubbery, you block those areas if it is a bigger one. Then re-excision specimen, a separate re-excision specimen may therefore be taken either one at a time or initial surgery. If a radiologic abnormality extends to the closest margin, suppose you say there is DCIS at the inferior margin, a tumor is at the inferior margin, the surgeon is going to send you a re-excision specimen with a permanent specimen. Then the surgeon may undertake an immediate re-excision of the particular margin. Similarly, if there is a surgically palpable abnormality extending to the closed margin, the surgeon may undertake an immediate re-excision. Re-excision specimen again should be weighed and serially sectioned at the interval of 3 to 5 millimeter, and block should be recorded in such a way to permit accurate measurement of the adequacy. So in this, if it is a bigger one, you take the denser areas. If it is a smaller one, you put through the entire thing. Again, re-excision usually have a cauterized and a non-cauterized edge. So you ink the cauterized edge in one color, that is the real excision margin, and the non-cauterized is towards the prior excision, so that is not a true margin. So ink that in one color, and you mention if there is any lesion and how far is the lesion from the cauterized edge and how you are inking the cauterized edge. Then mastectomy specimen for invasive cancer. So this one I think I'll keep for the second class. I would not go for mastectomy and lumpectomy now, because that is, I'm going to go in my second PowerPoint in detail. So I can take a few questions here and how you all do for your DCIS cases and all. Suppose, let me ask you this question. Suppose you have a specimen submitted to you, which is a lumpectomy specimen, and there was a diagnosis of just DCIS on needle core biopsy. How you are going to work on that specimen? It's a lumpectomy. It's a 5 by 4 into 3 centimeter lump. Anyone? Nobody? Yeah, to look for DCIS. So you have a 5 centimeter lumpectomy specimen. So one thing, you are definitely going to look for DCIS and look for invasive. Suppose you do not have any invasive cancer. How you are going to measure the DCIS? That is my question. You have a specimen of 5 centimeter in the long axis. You probably sliced it into 10 slices. Slice number 4, 5, fourth slice, fifth slice, sixth and seventh. 7 slices, the fourth, all the slices, they have DCIS. And the longest dimension of the DCIS is 1 centimeter. So what is the size of the DCIS? 4 slices, 5 millimeters suppose. So 5 into 4 is what? Being the specimen first, great. Slice 3 to 5, then identify the form. Gray white, I would all recommend you do not use the word gray. It is tan white. Nothing is in our organ. The slate gray is the only area where you have mixoid change. You say slate gray. Rest all is tan white, tan yellow, tan brown, tan red, tan black. And so you suppose you have like 4th, 5th, 6th and 7th slices with a farm area. You sample the entire area. And 4 slices, suppose you have done like 5 millimeter slicing, then you have 5, 5, 5, 5. So it is like 2 centimeter, 20 millimeter or 2 centimeter, and one extent is 1, so it is 2 into 1, and you have a multiplication factor of 0.4. So that would be the size of DCIS. And the margins in this specimen, you take the margin perpendicular to the lesion, and for the lateral and the medial, or the superior and the inferior, or anterior and posterior, whichever at the farthest margin, you again take the save or the on first margin and you cut it perpendicularly. Any question? Any question you have, you please bombard me with the questions in the group so that others will also see the questions and we'll go from there. Yes, please go ahead. The typical multiplication factor is 0.4 because we normally what happens, the typical factor 0.4, why? Because the studies which are done and they have shown, if they do the study with 0.2 and 0.4, so they have seen when the reproducibility of the exact radiologic and pathologic size of DCIS matches at 0.4 or the 4 millimeter. And also, if you are taking a slices at 3 millimeter, then 0.4 is suitable, and 0.5 millimeter is a little thicker slice. So try to go to 3 millimeter, 2 millimeter slices, and 2 is impossible kind of, 3 is fine. Then 0.4 is the ideal measurement. I'll send you the article by one of my mentor where they published this DCIS measurement. Let me just pull it. The question is, yeah, you can use 10% acetic acid. So some people, they use also 0.3. So it's basically recording the number of blocks involved by DCIS. Then suppose there are 4 blocks involved by DCIS. So you know 2 dimension from the slide, you can do 2 dimensions. Then you multiply by the, if you are taking 4 millimeter slices, you do 4, 0.4 is 3, it's 0.3. If it is doing 2, it is 0.2 is 5. 5 is the bigger one. But ideally it is people do with 0.2 or 0.4. And the accuracy is about 97% if you are doing a 0.4 multiplication factor. Yes, we need to give the DCIS measurement. It is necessary in the report. and margin involvement by DCIS. So I think there is, should you block the entire margin in all? Can you just unmute yourself and ask the question? I did not get your question.
Good evening,
Rashmi?
sir.
Yeah, good evening.
Sir.
Yeah.
Sir, for the lumpectomy specimen, you have given an example like the tumor is in slice 4, 5, and 6. So if we are taking perpendicular margins, should we take entire margin for?
No, you don't have to take the entire margin. Wherever the tumor is close to that margin.
Okay, sir. And sir, how many margins should we take for each?
Anterior, posterior, superior, inferior, medial, lateral.
Sir, I mean for the anterior margin, we have to take
One.
only
Yeah, which wherever the tumor is close.
Yes. Thank you.
You just have to see, suppose you think like you are a surgeon. Always a surgical pathologist should think like a surgeon. You have taken that specimen out. How far is the tumor for the different margins?
Okay, sir.
And try to appreciate cautery when you are holding a specimen at a fresh state. So when you know these are the cauterized areas, then you know the surgeon has basically fried the tissue that area and take it out.
Okay, sir. Thank you, sir.
You're welcome. Are this discussion useful for you? I'll go very slowly. I would not rush. We'll take more and more classes. And because my main goal for all of you to understand what we are going through. What if we cannot identify DCS? You mean, can you, Suhas, can you just unmute and ask the question? Sharanya, Suhas Sharanya, yeah. Could you please unmute and ask the question? I didn't get your question.
Hello, sir.
Yeah, hi.
Yeah. Suppose if there are no hard areas or whitish areas or fibrous areas running around where you suspect DCIS, so how to go about that? In that
You mean
case?
there is a needle core biopsy diagnosis of DCIS, but in lumpectomy, you did not find any tan white, farm, or white areas. That is
Yes.
the question?
Yes, sir.
So in that case, it is difficult. You just have to do a guesswork of any white area you see and take those. You have to very extensively gross it. Sometimes the good breast surgeon, they localize the area with a needle. If they localize the area with a needle, it is easier. Or you can ask the surgeon to kind of guide you through after slicing. Or thirdly, the third choice is kind of little sophisticated. If you have a faxitron or X-ray machine, you can X-ray and see the calcification areas. Because DCIS can present as a mass or a calcification.
Okay. Thank you.
Or you can send it to a radiology department if they can do a X-ray for you, specimen X-ray. They do it.
Yeah, thank you, sir.
Otherwise, the worst thing is you have to extensively gross it. Then. No, if there is a clear-cut invasive carcinoma, then you do not have to mention the size of DCIS. An approximate is fine. But if the DCIS is present at the margin, you should mention. How far the DCIS is from the margin when there is invasive carcinoma is kind of redundant. That's a very good question. What is base? You mean posterior margin?
Sir, should we give separate sections from base or we should save the posterior margin?
I mean, see, base is usually what is the posterior margin. Sometimes the base can be inferior margin also. So, the way I was taught it, I always say superior, inferior, medial, lateral, anterior, posterior. I do not use the word base.
Okay, okay, sir.
You mean for mastectomy specimen or for lumpectomies? For lumpectomy specimen, if it is an oriented lumpectomy, you can you can very well know like which one is anterior, which one is posterior, which one is superior and inferior, and if there's skin. In mastectomy, you have the skin. So you know, in mastectomy, you can use the word base because that is usually the posterior surface.
Okay. Thank you, sir.
Yeah, make a habit of taking all the margins because that helps. We don't miss out anything. But nowadays, what is happening, when we were resident, we used to get like big tumors. Like I was talking from 96 to 99 when I was doing my MD. That time we used to get like huge tumors. But now the tumor size is like, specifically you're practicing in an urban area, it is like 2 centimeter, 1.5, 1.8. So that case, your margin assessment is very, very important. Yeah, in mastectomy, posterior is same as a deep surgical margin. Yes. Yeah, deep is not resected margin. Please avoid saying resected. It is deep resection margin or posterior resection margin. It should be also taken perpendicularly. Yes. You're welcome.
आज ना यहाँ 6th फ्लोर में कोई एक सीए रहते हैं, सिर्फ यहीं पे 6th फ्लोर में एक सीए रहते हैं, उनका लड़का भी सीए है.
Dr. Bedi, I think we can stop here today. It's like 10 minutes after 10 o'clock. And when is the next lecture for this group?